My name is Jennifer Dorth. I'd like to thank the Anal Cancer Foundation for inviting me to speak to you today about approaches to improve quality of life for anal cancer on the ECOG Akron 2182 DECREASE study. I'm a radiation oncologist at University Hospitals and Case Western in Cleveland, and I'm the principal investigator for the DECREASE study. Here's the outline for my talk. First, I'll discuss a background, including history of anal cancer treatment and quality of life after chemoradiation. I'll give an overview of the DECREASE study and quality initiatives we utilized. Related to current care, I'll talk about options for personalization and side effect symptom management. I'll also talk about future directions. As a history of anal cancer treatment, I want to point out that prior to the 1970s, treatment for anal cancer was surgery, which resulted in a colostomy bag. Then a surgeon named Norman Nigro in Michigan came up with the idea of treating with chemoradiation, first prior to surgery, and then he realized many patients had a complete response and didn't need surgery. So then chemoradiation became standard of care treatment for anal cancer. A big improvement in radiation delivery happened with intensity modulated radiation therapy, or IMRT, in 2010. And this was shown to reduce dose to normal tissues and thereby reduce side effects of radiation. Now, currently, we're trying to personalize treatment where clinical trials tailor treatment dose to cancer stage. Related to patient-reported quality of life, it's important to note that patients report increased symptoms across the board at the end of chemoradiation. By the time 1 to 5 years pass after treatment, side effects which can persist include fecal incontinence, anorectal pain, and sexual dysfunction in some patients. This study looked at quality of life related to bowel function after chemoradiation and shows that patients report changes, including increased urgency and frequency of bowel movements in 50% of people, and about 30% of patients have incontinence after chemoradiation. The DECREASE study rationale was that de-intensified chemoradiation for early-stage anal cancer could maintain treatment efficacy while reducing side effects. The DECREASE study included 252 patients with tumors measuring 4 centimeters or less and no signs of concerning involved lymph nodes. Patients were randomized between standard dose chemoradiation and de-intensified chemoradiation for a dose of 50.4 gray in the standard arm and 36 to 41.4 gray in the de-intensified arm, depending on tumor size. The study endpoints were disease control, hoping to maintain it above 85% or greater while improving anorectal quality of life in patients on the de-intensified arm. I want to point out a few key secondary endpoints that have the potential to improve quality of life for all patients with anal cancer in the future. One endpoint is to validate features of low-risk lymph nodes in order to more accurately stage patients. Another endpoint is to measure serum testosterone and correlate it with male sexual function. In addition, we will correlate vaginal dilator use during radiation with female sexual function. And in the future, we hope to determine if detectable circulating tumor DNA in the blood related to HPV is associated with a worse outcome. And could that be used to adjust dose of chemoradiation to customize treatment in the future? I want to point out that there are other trials testing different chemoradiation doses that you'll hear about today. This includes the ACT4 study as part of Plato in the UK for early stage cancer, as well as the ACT5 study in the UK for advanced stage cancer. I want to talk about quality initiatives for the DECREASE study. Central imaging review was important for patients who were HIV positive because it can be hard to stage patients who also have inflammation related to HIV infection. We performed a central radiation plan review for all cases to be sure that plans met trial-specific radiation guidelines. In the trial guidelines, we included new trial-specific dose goals to better protect normal tissues. We also created videos to educate patients about the study, as well as about the history of anal cancer treatment. Here you can see highlighted in red the new dose goals we included in the DECREASE trial for bone marrow, gluteal cleft skin, and vaginal wall. I was also happy that the ASTRO guidelines published this year in 2025 also included these new normal tissue dose goals as well. In terms of bone marrow toxicity, new research has demonstrated that active bone marrow depicted in red is largely in the lumbosacral spine here, the pubic bones, as well as the femoral heads. So this tells us we should work to protect all the pelvic bone marrow from getting radiation dose the best we can, not just the iliac crests, which is what we protected in the past. In addition, we now know that it is important to reduce the low radiation doses to the bone marrow all the way down to 10 gray, and not just the moderate doses of radiation of 40 gray that we focused on before. On the DECREASE trial, we gave women the option to use vaginal dilators during radiation to potentially improve sexual function. The rationale for this is that higher radiation dose to the vagina can cause more vaginal narrowing, and dilators can decrease the dose to the anterior vaginal wall. As an example of this in the picture, you can see the target area is outlined in brown, which is the anal canal. The vaginal dilator is this bright white cylinder that you see here. And you can see by having this dilator, it expands the vagina so that the prescription dose of radiation can bisect the dilator in half, which protects the front anterior part of the vaginal wall from getting the prescription dose. I want to point out that in one study, among women who opted to use a vaginal dilator during radiation, 80% of them were able to continue using it throughout the 5 to 6 weeks of radiation. In the DECREASE study, we carefully considered that there are many challenges to measuring sexual function. It is critical to adequately measure sexual function in our patients in order to determine what issues are and how can we come up with strategies to improve sexual function. So challenges include measuring sexual satisfaction and distress in patients who are both sexually active, as well as patients who are not sexually active, and also how to tailor this to patients who are cancer survivors. It is also challenging to measure the anatomic and tissue effects that result after radiation. In addition, it is important to assess therapeutic aids that patients may use and could improve function. That includes hormonal supplementation, vaginal or anal dilators, moisturizers, lubricants, and therapies for erectile dysfunction. Below, these are the names of the quality of life questionnaires related to sexual function that we used in the DECREASE study. So before any results are ready from DECREASE, let's talk about current care and what can be done to improve quality of life. As we've discussed, the high burden of side effects associated with chemoradiation are used for personalization of chemotherapy and radiation dose to minimize side effects. We should measure patient-reported quality of life in order to guide survivorship care and take a multidisciplinary approach to manage side effects. As part of current care, I was happy to see that the ASTRO and ASCO guidelines were just published this year. They conclude that several concurrent chemotherapy options are curative for anal cancer, but have different side effect profiles. In addition, a range of radiation doses have been used to treat the primary tumor and elective nodal regions. Therefore, it is very important to have a doctor-patient discussion for decision-making. As part of this discussion, patient and tumor factors should be considered to select type of chemotherapy. In addition, we should consider the potential benefits and risks of higher radiation doses and whether to use them. Currently, there are many options to manage side effects. For patients who have problems with bowel function, diet modification, Imodium, psyllium husk, bile acid sequestrants can be used. We now recommend proactive referrals to physical therapy and pelvic floor therapy for all patients. We recommend vaginal dilators for women during the 1 to 2 years post-treatment and give women the option to select using vaginal dilators during radiation. We recommend moisturizers and lubricants to the genital skin and/or vagina to protect the tissue. We also recommend avoiding pad use and wet wipes. Hormonal supplementation can be considered for patients who have sexual dysfunction, such as topical estrogen to the vulvovaginal tissue and testosterone supplementation for men with erectile dysfunction or low libido. Many centers are now also screening the pelvic bones for decreased bone density after radiation, so patients could be considered for therapy. In terms of future directions for the decrease trial, we completed accrual a year ago. We expect results not until 2028. But in the meantime, we are working on our radiation quality assurance experience to report that. We're also starting to study biomarkers, including circulating tumor DNA from HPV. We are also working with the UK Plato group on a pooled analysis for ACT4 and ECOG-ACRIN 2182. Another direction we're excited about at Case Comprehensive Cancer Center is a pilot trial where we will be opening soon. This is called HPV circulating tumor DNA response-adapted chemoradiation with or without retifanlimab in advanced stage anal cancer, or the CHART-AC trial. Thank you so much for your attention today. I would also like to thank our decrease study team listed here. I am looking forward to talking with all of you later today during the question and answer session.